Time ever speaking to a group of nurses, I'm usually talking to a bunch of doctors, so this should be good for all of us. And when I was planning my talk, I was trying to think, what do you guys want to hear from me? How can we do something together to make it easier and better to take care of patients? Most nurses love their job, they love being at the bedside, they want to know more things about medicine and how to take care of their patients better. They want to call the doctor when it's right to. They don't want to make unnecessary calls. They want to do as much as they can for their patients. And they want to recognize when their patients are having problems so that they can notify the physician. So since I'm a neurosurgeon and I've spent the last 8 or 9 years doing neurosurgery and interacting with nurses, and I've seen good nurses and bad nurses, I thought, I'd try to express to you guys, teach you a few things that I thought could make you better neuro nurses. A lot of times, people say, I'm not comfortable with this patient who has a neurosurgical problem. And all that really means is you're not quite comfortable really with the neurological exam. The neurosurgery, the two most important things in determining a patient's acuity of illness is their scan and really their exam. The exam is so valuable in what we do, and it basically dictates the direction that we take with all of our patients. And some patients may have a scary diagnosis, a subdural hematoma, but if they have a very good neurological exam, they do not have an emergency. And I feel if I can educate you guys a little bit about the very basic components of the neurological exam, you'll be better neuro nurses. You guys are on the front lines, you're at the bedside, you're the best caregiver positioned to see a patient having a neurological change, recognizing it as a problem, initiating basic care at the bedside to improve their outcome, and notifying the doctor so he can come in and provide either definitive orders or surgical treatment if that's needed. MDs obviously try to be advocates for our patients, but honestly, you guys are the patient's best advocate, especially when they're having trouble. So understanding the neurological exam, it's a language that we speak to one another. This patient has a GCS of 14. Their eyes are open. When I ask them to open them, they follow all commands. They have fluent speech. That means something. If somebody tells me that, I know the patient's doing pretty well. If they tell me, this patient has a GCS of 4, right? They're extensor posturing and they have basic brainstem reflexes. That's a completely different story. That's one sentence that you're able to communicate a concern to me, and I already know right then and there, I gotta be worried, I gotta get my butt into the hospital, I gotta go see that patient right away and gotta start working on them. So I'm gonna do my best to try to teach you some very basics of the neurological exam so that you and we can all speak the same language. So the GCS scale, the Glasgow Coma scale, has 3 basic components: E, V, and M: eye opening, verbal response, and best motor response. So the best score anybody can have is a 15. Right now, unless you're sleeping through this talk, we all have a GCS of 15, okay? And if you're one of Dr. Beasley's brain dead patients, or if you drank too much the night before and you can't wake up, you're a GCS of 3, okay? So the worst you can have is a 3. That doesn't necessarily mean you're brain dead, but you are getting very close. All right, and a GCS of 15 is the best you can have. Approximately 8 is where we cut off and say a patient's in a coma state or not. So if you know how to calculate and communicate a Glasgow coma scale, I'm going to be like, man, that nurse is on the ball, okay? Eye opening, 4 if you're open spontaneous, 3 if they open a speech, so somebody's dozing, will you wake up please? And they open their eyes right away. 2 to pain, okay? This is also sometimes people come into the ED, they've had too much to drink, they're passed out. You can't get them to shaking them, give them a strong rub. They finally open their eyes and they stop it. Okay, that's a 2. And then 1, of course, is no response. Verbal, you're oriented, you're not confused, you're you, okay? One last point, if you're confused or disoriented, but you still have fluent speech, you can still communicate. You just don't know entirely what's going on. 3, you're saying inappropriate things. but the words put together in sentences make sense. 2, you have incomprehensible sounds, so moans, groans, grunts, not words. 1, no response. Best motor, following commands. I ask you to do something, you process the language, you understand it, and you follow the command. That's the highest order you can have. 5, you localize, so somebody's in bed, you provide a painful stimulus to see what they do, and pinch them in their arm, and they take their other arm to remove the stimulus. That's localization. Withdrawal, say I pinch them here, and they're trying to get away from it, as opposed to actually putting their hand to the stimulus to remove it from them. And then 3 and 2 are reflexive exams, flexion, which I have an example here on the side. The patient flexes their upper string, or decerebrate rigidity is when pain is applied, their arms go down like that. And if you've seen this before, you understand. It's kind of hard to miss once you learn it. So again, calculating this GCS score is a great way for you guys to understand just how sick your patient is, how concerned you need to be about them, how quickly you need to intervene, act, or communicate their condition to a doctor or another provider. When you have a comatose patient, you got to check brainstem reflexes, right? Because they can't do these things. They can't open their eyes, they can't talk to you, they can't follow commands, they probably have some kind of reflexive motor score. So the way we check for brainstem function to know if a patient is having brainstem herniation or high ICP issues is to do basically a cranial nerve exam. Cranial nerves come out at the base of the skull, different parts of the brainstem in a predictable way, and they all do predictable things. So number 1 is the sense of smell. All right, we usually don't check that. But number 2 is your optic nerve. And number 3 is your oculomotor nerve, but also is responsible for your pupil reactivity. So by shining a light in someone's eyes, you can check 2 and 3 at the same time. And essentially it's 3. 3 comes off part of the brainstem where patients can sometimes have uncal herniation. Uncal herniation is the uncus is a part of the temporal lobe that when there's brain shift, it can crush against this cranial nerve number 3. So when you check for reactivity, that's what you're checking for. Number 5 is the corneal reflex. So if you touch your patient's cornea lightly with a gauze or drop some normal saline in there with their eye open, they should reflexively blink. That tells you that number 5 is still working. 9 and 10 are usually cough and gag, deep suctioning, stick the ET tube against the back of their throat, try to make them gag on it. These, as we go down, these cranial nerves exit at lower parts of the brainstem. So more primitive function, all right, the lower we get. And then the medulla is respiratory. So a patient may have a GCS of 3, they may not have pupil reactivity, corneal reflex, cough or gag, or any of the other basic brainstem reflexes, but if they are still having spontaneous respirations of some kind, even if they're weak, something's going on in their medulla, they're not yet officially brain dead by exam. And then of course, you should know your motoric scores, okay? 0, 1, 2, 3, 4, 5. 5 is strong against complete strength of any muscle group, whether it's bicep, tricep, you name it, any muscle in the body. 4, which can be divided into 4 plus 4 and 4 minus, is they have some strength, but not full strength. 4 plus, they have slightly less than full strength, and they do break against some resistance. 4 less than that, 4 minus less than that. 3, they can move the muscle against gravity, but no resistance. So if a patient can pick their arm up off the bed, but as soon as you apply any force to it, it drops. That's a 3. 2, they can't even lift it against gravity, but maybe they can flex at the joint. For instance, the bicep, they can't do like this and pick it up against gravity, but if you lay it on their chest, they can flex and bring it up to their mouth or something like that. 1, you'll see a little flicker of activity in the muscle, but there's no real function going on, and 0 is nothing. So in certain neurosurgical conditions, if the patient can cooperate and give you a motor exam, you need to pay close attention to it, because if it changes over time for the worse, and they have certain neurosurgical diagnoses, they could be having a neurosurgical emergency. And the last thing I'll say is look for localizing signs. So patients with a subdural, for instance, may have a pronator drift. where if they have a subdural on the right, their left arm, they can't hold it up as strongly and against gravity as the other side, and you'll see it kind of drift down and they'll pronate the hand a little bit. So things like that, these are the basics of the exam. The neuro exams obviously can be very subtle and complex at times, but these things here, if you know these very basic things, you're leaps and bounds ahead of your colleagues. And then of course, since we're talking about emergencies, we want you to know about the very basics of ICP management, because a lot of neurosurgical emotions are essentially just problems with the patient's ICP, regardless of the structural pathology. So the principle of ICP management is based on the Monroe-Kelly doctrine. The brain lives in the skull, which is a hard and close compartment. There can be no extra room can be made unless you get rid of the things inside of it, which are brain, blood, and water, or spinal fluid. When you start adding something extra, like a mass lesion, a tumor, a subdural, something, the space is enclosed. Some of that stuff's got to leave in order to accommodate space for this new thing. So that is why we often put an EVD in. We get rid of the water in the brain so there's more space. Or hyperventilation causes the blood vessels to constrict so there's not as much blood volume in the brain. You want to keep your patient's head up, neck midline, so they can have venous drainage so there's not as much blood in the brain. So all the things that we do for ICP management are based on this principle. Once you reach a critical point where nothing else can be removed from the head because the space-occupying lesion becomes too large, you can start seeing ICP issues, brain herniation, emergent things. So the basics of ICP management, head it up. If in doubt, if you think your patient's having a neurosurgical cranial emergency, you're worried about their ICP, nobody's ever going to be upset with you if you put their head up, keep their neck midline for that venous drainage, pay close attention to the ICP monitor or EVD if they have one, make sure you know how they work, that they're leveled appropriately, that you've zeroed it, that you've got an accurate measurement, that there's a good waveform, that it fluxes. If you lift it, the fluid column should go down. If you drop it, it should flow forward. That's a functional external ventricular drain. Hyperventilate. If you realize your patient just blew a pupil, you're reaching for the phone to call somebody, start hyperventilate, do all these things. You can do all these things. You don't need orders. You don't need permission. You can be the person that makes a difference in someone's outcome. Sometimes we do hyperosmolar therapy. We have mannitol, 3% saline. The sodium drives water out of the brain. And that's, again, the Monroe-Kelly principle, trying to get extra fluid off the brain. So when we're doing those things, watching the sodium, sending them on times and making sure the lab gets them, keeping really close eyes and O counts for us in the chart. I mean, these things make a world of difference. When we're checking on our patients and we're looking in the chart, when these things aren't there, it's like, well, what's going on? The cerebral perfusion pressure is essentially the MAP, or the mean arterial pressure, minus the ICP, and the goal is 60. So always keep that in mind, because if a pressor needs to be started to make sure somebody's brain is perfusing well enough, that's important. On the other hand, if they have a problem in their head that requires them to have good blood pressure control and it can't be too high, sometimes they'll need a cardiac drip or something like that. Other things we can do besides surgery for ICP management is paralyze the patient. They're having ICP issues and all these other things aren't working. And every once in a while we'll put the patient in a venovar coma. And then of course, if all that fails, or we get to a point where we think surgical decompression would be the best thing, we take them to surgery and do a hemi-crani, and sometimes on both sides. So in order to understand neurosurgical emergency, you have to know a little bit about intracranial hemorrhage. Intracranial hemorrhage is a very general, broad term, and it basically consists of several different diagnoses based on the location of the bleeding. Okay? If a patient has an epidural hematoma, that is blood outside of the brain, outside of the meninges, between the meninges and the skull. If they have a subdural hematoma, the blood is inside of the meninges, pushing against the brain. Those two have different appearances usually on scan. The epidural kind of looks like a lens. It's called a lentiform shape, and the subdural usually is described as semi-lunar. It conforms to the curvature of the brain. It looks like a half moon, quarter moon. Subarachnoid hemorrhage is bleeding that occurs in the space of the brain where the blood vessels are. In the subarachnoid space, there's the dura, and then there's a subarachnoid membrane beneath that. That's blood up against the brain. Intraventricular hemorrhage is bleeding inside of the brain ventricles, and intraparenchymal hemorrhage is bleeding within the tissue, the parenchyma of the brain itself. Determining whether intracranial hemorrhage is emergent or not is of course based on how it happened. Was it a high-speed MVC? Was this acute? Or was this something that happened days or weeks ago? Of course, the way it looks on scan, and above all, which if you leave here today with remembering one thing, the neurological exam is probably the most important thing when caring for a neurosurgical patient. So a little bit about intraventricular hemorrhage. Not all of these are always emergencies. Knowing when something's an emergency is what this talk's all about. IVH can result sometimes from trauma, high blood pressure, strokes in the basal ganglia of the brain that spreads into the ventricle, ruptures into the ventricle. And if it is significant in its volume, it can obstruct the outflow of spinal fluid. Patients can develop hydrocephalus, their neurological exam can decline, and that becomes an emergency that usually requires, at the very least, placement of an EVD to divert that spinal fluid that can't drain on its own. Of course, anytime somebody has an intracranial hemorrhage and we're worried about them, we're always checking platelets, coags, and things, and deciding if there's a coagulopathy, if we should transfuse someone or give them desmopressin or something like that in an attempt to stop the bleeding without having to go in and operate. Subarachnoid hemorrhage. Two most common types are traumatic and what's called non-traumatic, and that usually occurs when an aneurysm bleeds or sometimes an AVM, very rarely a cavernous malformation. The vast majority of the subarachnoid we see in the hospitals we cover, of course, is traumatic. Just about anybody who hits their head hard enough is going to have a little bit of this. Some people don't even get scanned, you never know about it. Sometimes the ED scans everyone, even when they shouldn't, and they see a little bit. That's usually not an emergency. I can't remember the last time somebody had a little bit of traumatic subarachnoid that ever became a surgical emergency. On the other hand, aneurysmal subarachnoid, somebody's aneurysm blows, they're comatose or close to it, that is a neurosurgical emergency. You have to address several things. One, that can sometimes cause obstruction and hydrocephalus. They may need a ventriculostomy emergently to prevent hydrocephalus and brain herniation. But help us get that blood pressure controlled fast. Go get the nicardipine drip out of the dispensary sooner than later. Start it. By the time we show up at the bedside, that's running. The patient's blood pressure is nice and controlled. 120s, 130 systolic. ICP management, of course, when a patient has a really bad rupture, is important. We've talked about that. And then something called vasospasm. The blood irritates those vessels, and several days after the aneurysm bleeds, the patient may be doing well, they may be doing great, and all of a sudden they go into spasm. You're like, what is going on with this patient? Their exam can change, they can become confused, complain of bad headaches, have a focality to their exam, like I talked about earlier. Pay attention to all arms, all legs, do a pronator drift. Sometimes signs of spasm can be as subtle as their right leg's not as good as it used to be. So when someone has subarachnoid, they have a really good exam. They're about 3 to 10 days out from their rupture. Hey, do good neuro checks. Don't assume just because they're doing well, they're up talking to you, they're not having some issue that could become a problem. Subdural hematoma, we see a lot of these, typically caused by trauma. Sometimes they can happen spontaneously. Usually, in my experience, that's a remote trauma, weeks or months back, that kind of gradually the patient developed headaches or something slowly, it didn't go away. So, knowing the timing of onset, what kind of subdural the patient has, they can come in a variety of hyperacute, acute, subacute, or chronic. The radiographic findings are of course important, and the neuro exam is the most important to determine if there's an emergency or not, okay? These 3 scans are from 3 different patients, and I can guarantee you, although the size, the thickness of the subdural is similar, the amount of shift is approximately the same, they are doing differently, okay? The patient on the left has an acute subdural hematoma with brain shift, enlarged ventricles, and I'm sure uncoherniation. They probably just got into a car accident, motorcycle accident, fell off the mountain. They are sick and they are emergent and they need surgery right away. And while we're getting the operating rolling, you guys are doing the ICP control stuff for us. Head of bed up, hyperventilate, mannitol, all that stuff, making sure all those orders get carried out fast. Leave the charting for later, okay? Patient in the middle, he probably hit his head 4 weeks ago, and he's slowly, gradually building up this chronic subdural collection. There's shift on the brain. He's probably awake. He's probably talking to you. He's telling you, man, I have had this headache that just won't go away. Sometimes they'll have a little subtle weakness on the contralateral side. Face is not quite symmetric. Little pronator drift. Hand grip's not as strong. But these are two very different patients. This person is awake and talking to you with a GCS of 15. Obviously not an emergency. It doesn't mean they don't need surgery, but different scenario, and the exam tells you everything. Epidural can be a neurosurgical emergency. Sometimes they're very tiny, they don't grow, they're not. But the true emergent epidural hematomas, the classic presentation is somebody who got hit in the head. Skiing, unfortunately, takes a lot of people this way. A bat to the head, some blunt head trauma, where they lost consciousness, then they woke up. They had this period of lucency. And then inside, this epidural is slowly accumulating, and then all of a sudden their exam craps out again. You scan them, they've got this, again, like I said, a lentiform or lens-shaped finding, usually under an associated skull fracture, usually from tearing of one of the epidural arteries, okay, like the middle meningeal. This patient has an emergent brain scan. You can see it's a temporal hematoma, pushing that uncus, the middle part of the temporal lobe, over to the other side up against the brainstem. These patients go to surgery right away and take that out, and if you get to them in time, they usually do great. Some people even go home the next day like, wow, I feel normal. It's kind of amazing to see. So, blunt head trauma, closed head injury, this can be an emergency, right? It's essentially, a concussion is a form of blunt head trauma, okay? So usually when it becomes emergent, it's a result of a high velocity trauma or some kind of sudden acceleration, deceleration mechanism, all right? When someone gets hit in the head, say frontally, they fall, they hit the front of their head, they can have a skull fracture up front, they can have bruising of the brain up front, but the brain can jar, and they can also have that contrary coup brain injury as the brain hits the back of their skull. We see this a lot with the frontotemporal contusions. We have often these people in the ICU, they fell backwards, hit their head, slipped on the ice, and although they hit their head back here, they've got bleeding up front. That's a contrary coup injury. These can, of course, be a neurosurgical emergency depending upon the mechanism, the patient's scan, and their exam. And blunt head trauma can cause any and all of those intracranial hemorrhages we discussed earlier, including something called DAI or diffuse axonal injury that I haven't talked about yet. That's when the brain neurons, the tracts of the neurons get sheared with that jarring effect of the brain. They can get global brain swelling, and if that builds and builds and builds, they can have ICP issues, hence a neurosurgical emergency. So obtaining a neurological exam and scan, or again, what will determine if something's emergent. And then again, if someone's in a coma or with a depressed GCS, pay close attention to the focality of their exam. Something's not quite as good on one side as the other, indicating perhaps a subdural, something like that, and pay close attention to their cranial nerves. You know, they were in a deep coma, but their pupils were reactive, and now their right pupil is blown, it's fixed, it's dilated, the light will not react. It does not cause reactivity. That is an emergent change in their exam that you need to communicate right away. And then of course, if you notice something that's not quite right, initiate basic ICV measures yourself. Nobody will ever fault you for it. Then of course, patients that end up in the operating room and have a hemicraniotomy or an EVD or something, make sure you're up to speed on how to care for those. You go a long way. There's penetrating head trauma, okay? Usually this is caused by a gunshot wound to the spine. I saw a ton of these in Chicago, as you guys have probably heard about on the news. They are terrible. I hate when we have to take these to surgery because the patient is usually very, very sick, and if we consider them salvageable, okay, the bullet traveled in a certain location of the brain that we potentially feel we can maybe save their life, they are usually thereafter, if they survive, extremely injured, neurologically disabled, debilitated for the rest of their life. I have seen probably 100 of these, and maybe only 1 or 2 people make what we would consider a good recovery. Most people have an injury that is non-survivable, okay? We go in, we look at the scan, make a determination if surgery is even in the cards for them. Sometimes you'll see a patient, they still have neurological activity, but the bullet crossed from one end to the other through the ventricle, through the brainstem, you know there's just no point in doing surgery. When we take them to surgery, it's usually a mess in there, a lot of blood loss. This is a picture of me doing one as a chief resident with my junior. I think we lost 80 liters of blood, okay? This patient survived for about 2 months in a vegetative state and then succumbed to a secondary condition from being in a vegetative state. If they make it out of surgery, usually we spend the next week or 2 managing awful ICP problems, which you guys know how to do now. Posterior fossa lesions, I include this because if a patient has anything in the back of their brain, the posterior fossa and the cerebellum, what we call the infratentorial compartment, have the heightened sense of concern for them, all right? There's not as much space back there. Something small can cause a big problem, especially swelling. It can cause brainstem compression. It can obstruct the ventricle. They can develop hydrocephalus. You know, if somebody has a tumor back there they went for surgery for, or they have a stroke, you know, they're going to swell over the next several days. They may develop a neurosurgical emergency if their exam drops due to hydrocephalus or brainstem compression. So if you have a patient with something like this, just remember, these can go bad. I better pay close attention to their exam and do good checks and make sure their fluids are okay, their sodium's okay, and all those osmolar, hypertonic things we talk about. Again, hydrocephalus can be a neurosurgical emergency in the right setting. This is when the cerebrospinal fluid is usually obstructed or does not drain well, or is made in abnormal amounts for whatever reason. And in somebody with a brain shunt, for example, a VP shunt, if it fails and they really depend on that shunt and it was working and all of a sudden it stops, they can have an emergent problem from hydrocephalus. That fluid doesn't drain. Some people with shunts, they fail slowly and over time, more indolently, and they're awake, they're talking to you, they're telling you, now I've had this headache for 3 weeks, I feel nauseated. You know, this usually happens to me when my shunt starts to fail. Obviously, that's not an emergency. If she's just at 15, they're having a conversation with you. Even if you think they're having a shunt malfunction, it needs to be revised. You don't got to call the OR and come crashing in. It's different when someone has a shunt failure or hydrocephalus acutely that they can't tolerate. And again, in terms of your neurological exam, if somebody has true hydrocephalus and high ICPs from it and they're very sick and there's an emergency, pay attention to their vital signs. You can often see patients become bradycardic specifically. Tension pneumocephalus, I included it because it can be a neurosurgical emergency. It's very rare. I've only seen maybe 1 or 2 cases in my time that actually a patient had to go to surgery for to have that air decompressed. So it's just like anything else, you know, air gets stuck in the head, the brain is in a fixed volume. If the air keeps getting sucked in, sucked in, sucked in, it can actually accumulate to a size where the brain's compressed. The patient can become very sick and comatose. They have to be taken to surgery, the wound has to be reopened, craniotomy reopened, and then air decompressed. I remember one of these specifically where we did this, and as soon as we got inside, all of a sudden the air came out like a whoopee cushion. It was quite a sight. That patient was very sick, but that's really the only time I can remember doing this in the past 5 or so years. A lot of times people have pneumocephalus called on their scan by a radiologist, but this is, you know, it's normal to have a little bit of air in your head after surgery. The problem is when it keeps getting sucked in. Emergency, they need to be taken to surgery right away and decompressed to give them the best shot getting their vision back. Okay, this isn't something that you guys necessarily will recognize or need to treat, but with pituitary surgery, diabetes insipidus can be an issue post-op. So with any pituitary patient, please pay close attention to their eyes and nose, sodium levels, specific gravities, and send them, if ordered, in a timely fashion. And let us know if the patient has increased urine output or other things that are concerning for DI, so that we can act right away. CNS infection, okay, can be a neurosurgical emergency. If a patient has a rip-roaring, subdural lymphedema, or cerebral abscess, a lot of brain swelling, their neurological exam is failing, okay, they have fevers, high white blood cell count, you might need to go in right away and drain that out. Every once in a while, these can grow very slowly. They're encapsulated for whatever reason the bacteria contain, but most of the time, somebody with a cerebral abscess, it needs to be taken to surgery right away. From a nursing standpoint, if somebody has a brain infection or spine infection, please, if antibiotics are ordered, don't worry about the charting, just go get them out of the thing and give them to the patient when they're scheduled, okay? That's the most important thing, it's just getting timely antibiotics. If there's an issue getting from pharmacy, whatever, call me, we'll figure it out, but we gotta get them in right away. Sometimes we wanna wait until we go to surgery for them, but if they're ordered, that's one thing we can do to make a big difference. Status epilepticus, not a neurosurgical emergency, but a neurologic one. If someone has a generalized tonic-clonic seizure that will not stop, that is a neurological emergency, and no matter what we do, we got to make it stop. So if you can't get in touch with the doctor, just give them IV Ativan. If you can get in touch with somebody, Dilantin. But the number one thing is if that starts, patient's in status, we got to make it stop. If it goes on too long, they might not survive. So spinal stuff, cauda equina syndrome. Cauda equina can be an emergency if it happens acutely. The patient was doing fine, they bent over to pick up something heavy, all of a sudden they heard a pop in their back, their legs start feeling numb, their genitals are numb, they pee their pants acutely, okay? They go to the ER, they see this big giant disc fragment, they gotta call us right away. We're gonna go in there, we're gonna do a laminectomy and take out the disc. You gotta do it within a day or so, because if you lose bowel, bladder, sexual function, and you wait too long, you will not get it back. Every once in a while, patients can have severe lumbar stenosis, and they slowly and gradually start having these symptoms. And again, timing and onset are very important when we make a determination if something is emergent or not. Spinal cord injury, obviously, can be an emergency at times. Usually most of the time they at least need to be seen emergently and a decision needs to be made even if they don't have a surgical emergency. This is something that needs to be addressed emergently. So fractures with cord compression, okay, and their exam will dictate if it's an emergency. The ASIA exam is a scale we use to communicate the language of how severe someone's injury is. ASIA A means they're complete. They injured C5, everything below C5 is gone, motor and sensory. B, they have a little bit of sensory under there. C, they have some motor function, all right, below the level of injury, but half of their muscles are not anti-gravity. And 4, half of their muscles are more than anti-gravity, or D, excuse me, and then E is normal, okay? They may have dinged their cord, but they have a normal exam. So knowing how to take care of spinal cord injury patients, spinal precautions, how to keep their neck midline when you're rolling them for scans and turning them for cleaning, how to manage the traction if we have set it up, and sometimes we're IV steroids. Those are things that you guys may see and want to be familiar with. Do the best job you can for these patients. And spinal oncologic emergencies similarly are related to cord compression from some tumor or mass lesion and how acute the patient's exam changes are and what they are. Most of the time, if someone is having an acute neurological decompensation from a spinal cord compression from a tumor, we like to take them to surgery and at least do a laminectomy and decompress them so they can maintain function, specifically the ability to walk while they're having their disease treated. Every once in a while, something like myeloma is best treated with radiation, but most of the time, if there is an emergency, it's surgical. Spinal epidural abscess, similarly, if somebody has a big abscess collection of purulent fluid pushing on their spinal cord, they've got neurological symptoms, an exam change, that is likely an emergency. We got to take them to surgery, wash that stuff out. Okay, I want to distinguish between that and discitis osteomyelitis, which we get a lot of consults for. You probably have a lot of patients with that. Most of the time, that is infection contained to the bone and disc space without an associated epidural abscess, and that is not an emergency. Those patients usually aren't even surgical, and they just require antibiotics. So knowing the difference between those two is an important distinction. If a patient has a collection, the epidural space pushing on the spinal cord or nerve roots of the cauda equina with an acute neurological exam change, that's an emergency. If we're watching somebody on the floor in the ICU, we're worried is on the edge, might need surgery, pay close attention to their motor exam, because if you notice changes, or you notice they start retaining urine, make sure you do a bladder scan, check their post-void residuals, see how much they got in there when you straight cath them, and let us know. That's a very important, valuable information that helps us make a determination. Is the patient approaching an emergent situation? Do we need to take them to surgery? So, you guys are all good nurses, you all love your jobs, you want to help your patients, you want to be their advocate, you want to make sure they have good outcomes. So, from a neurological standpoint, you knowing these basic pathologies they might have, and when somebody has a problem that could potentially be an emergency, puts you ahead of the game. Knowing their neurological exam, being able to communicate it effectively to doctor or another nurse, puts you leaps and bounds ahead of the game, makes you a true neuro nurse. Understanding the basics of ICP can help you guys make quick interventions, improve someone's outcome while you're waiting for a doctor to come and provide definitive surgical treatment. And always remember speed. If we recognize something as an emergency and we're all working together to get this patient taken care of, speed is important. Stay calm, but move as fast as you can. Times brain or spinal cord. And don't worry about the charting, save it for later. You can do something basic as go and get a medication, starting it right away. You can make a dramatic impact on your patient's life and recovery, and change their life for the better forever. That's all I have today.